Professor Edward Johnson, the organizing team of this online CME, all my friends, professors, delegates, and ever energetic postgraduates, a very good morning to you all. So today I'm going to talk something on very basic on pain, the basic facts. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, who is currently the director of e-learning in MGMCRI. So what is my talk is going to go about like definition, pathway, taxonomy, some pathological terms and meanings, the descending control of pain, and practice spells linking physiology, anatomy, and pharmacology. What is the definition of pain? So little older definition, but it is staying still. An unpleasant sensory and emotional experience. See, here it's not only a sensory, it's an emotional experience. It is unpleasant. It is associated with actual or potential tissue damage. Actual damage or potential tissue damage. It cannot be two also, described in terms of such damage. So it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Some say an unpleasant sensation occurring in varying degrees of severity as a consequence of injury, disease, or emotion. Pain has always got a subjective component. So this is Professor M.R. Rajagopal. He says pain is something which hurts. So what is nociception? What I understood is nociception is activation of a nociceptor, a potentially tissue damage, the noxious stimulus. It is the first step in the pathway. Some damage is done, and probably I think the emotional or the affective component is not there. It's a sensory component which makes no detection. For example, rat tail clamp. That is a form of nociception. A nociceptor is a specialized neurological receptor capable of differentiating between noxious and noxious stimulus. What we have is A delta and C fibers. Now, how is pain perceived? Now, we know A delta fibers and C fibers. This is myelinated, this is unmyelinated. So, this is diameter we can see here. This is myelinated S and unmyelinated S. This is for first pain and this is for the second pain. So pain starts by the nociceptors here, and then it travels along from the A delta C fibers to the dorsal horn, and from there it synapses in the second order neurons of substantia gelatinosa, and from there it ascends contralaterally, other side, and goes in this side, and it reaches the thalamus, spinothalamic tract, and from there the thalamocortical projections. Yes. Posterolateral nucleus of the thalamus. Paleospinothalamic neurons known as the C fibers. Neo அப்படிங்கிறது more of A delta fibers. From the thalamus, the third order neurons to the cortex. And the cortex we can have anterior cingulate cortex, the emotional aspect, and the somatosensory cortex is the actual noxious painful sensory cortex. Now, there is also the second order neurons. From here, this is the first noxious stimulus. From there, the first order neurons, synapse here. The spinothalamic tract goes above. From this, the third order neurons, the thalamocortical projection system and the cingulate cortex and the somatosensory cortex. But it is not the only thing. Sometimes we can have spino-mesencephalic. Mesencephalic, the midbrain. So behavioral responses to pain. Spino-reticular system, reticular formation, motivational aspects. All these things are also there. So from there, first, from the dorsal horn, first order neurons, lateral spinothalamic tract, thalamus, and the cortex. Also, we have spino-reticular and spino-mesencephalic. Yes, I'm again telling you this is the pathway of first order neurons, the second order neurons, and the third order neurons. So what is, we will, this is the basic anatomy of pain. So we will go to what are some specific terms associated with pain. Patient has no pain, but he has got the noxious stimulus. That is what is called analgesia. Patient has pain, but there is no painful stimulus. Then it is not called analgesia. Anesthesia means all sensory modalities are gone, while analgesia means only pain is gone. Paresthesia means abnormal sensation. Either it may be spontaneous or evoke. We can evoke a paresthesia, or it may come as an abnormal sensation in paresthesia. It may be either painful or painless. Painful paresthesia is sometimes called dysesthesia. Formification, leave out this. Now we have one more term called anesthesia dolorosa. Anesthesia in all sensory modalities are gone. Dolorosa na pain. All sensory nerve is gone. Still we have pain in that area. That is what is called anesthesia dolorosa. You just ablate the trigeminal nerve. There is no sensation. If you touch, we cannot feel. But this, the neuralgic shooting pain comes. This is called anesthesia dolorosa. Hyperpathia refers to an abnormally intense response to a repetitive stimulus. Algogens, algona, algesiana pain, analgesiana pain relief. Algogens na pain generators. What are these pain generators? Histamines, substance B, potassium, prostaglandins, bradykinins, serotonins, etc. When injected also it produces nociception. So what is hyperalgesia? Now you have a stimulus. This is the normal pain response. If the pain response is more, then it is called hyperalgesia. So shift it to the left and not right. So shift it to the left. Pain to a non-noxious stimulus in the injury. Sometimes pharyngitis, swallowing painful. That is called allodynia, non-noxious stimulus. So there is something called primary hyperalgesia and secondary hyperalgesia. It starts within minutes and the area of injury. This is go to peripheral sensitization. Peripheral nerves, nociceptor, there is some change. So small pain stimulus, big pain is sensed. That is sensitization. So secondary, delayed onset, wider area, only thermal stimulus, and there may be a central role. Primary hyperalgesia, there are so many mechanisms. Camp levels and PKCs have been explained. Antidromic release of algogens. Dorsal horn neurons become sensitive. Wide dynamic neurons. WDR neurons. There are some plastic changes. Sometimes they are irreversible. Now, what is sensitization? We all told hyperalgesia is due to sensitization. If the stimulus pain is more means the shift to the curve is left. Then it is called hyperalgesia. The fiber response is more, then it is called sensitization. This is more of an electrical sensitization. That is more of a clinical hyperalgesia. So it means a peripheral receptor or a central response, more intense fashion. So it can occur in the nociceptor in the periphery, or it can occur on the spinal cord. So this is about the various terms what we have. Hyperalgesia, hyperpathia, allodynia, anesthesia dolorosa, sensitization, so many terms. Allodynia means there is no painful stimulus. Touching a patient with pain. So these are all some of the terms. Now we go to classify the pain. Why do we need to classify the pain? We need to understand the where from it has come from and the treatment modalities. From there, we can judge the prognosis. So, if you want to go as a temporal classification, acute, just we have a trauma, elbow injury, knee injury, it's an acute pain, acute gastritis. Chronic means it persists for more than 3 months. For example, the patient has got an intercostal neuralgia, post-herpetic neuralgia. Recurrent means duodenal ulcer. There are other classifications according to the etiology, according to the site. Nama first என்ன சொன்னோம்? Classification according to the temporal, time-based, acute, sometimes subacute, around 3 weeks. More than 3 months is chronic. Now we have a classification depending upon the etiology. It's an arthritic, a malignant pain. Where is the pain like? From the appendix, from the breast. This is one type of taxon. What is more important is whether it is a nociceptive pain or a non-nociceptive pain. Nociceptive na noxious stimulus is there. Somatic nociception. If you have a trauma, injury, if you have some paronychia, pus in the nail bed, that is somatic nociceptive. Visceral means there is appendicitis. Non-nociceptive is neuropathic, central, and psychogenic. There is no noxious stimulus. Nociceptive somatic, yes, we know toothache. Very simple example. It increases with movements, dull or sharp, localized. Now we can have so many examples of nociceptive somatic pain. Yes, visceral nociception, renal pain, appendix pain, autonomic sensations will be there, nausea, vomiting, sweating, especially with visceral nociception. Neuropathic means yes, burning, electrical, sometimes numbing. The intervening period is normal. Certain areas, just a burning sensation for half an hour, then it becomes normal. Intervening period is normal. That is not there with nociceptive stimulus. Sudden, post-herpetic, trigeminal, glossopharyngeal, neuralgias. Now we have central pain syndrome is a neurological condition, but tumor, stroke, Parkinson's disease. This side stroke means they will have complete pain. Continuously they will have pain. This is very difficult to treat. There are a lot of theories which have been proposed for this neuropathic pain. Specific cellular and molecular changes that affect membrane excitability. New gene expression after nerve injury. So many things. For example, ectopic impulses of neuroma, changes of sodium calcium channels. So many things have been proposed for neuropathic pain. Psychogenic pain. What we have now is nociceptive, somatic, visceral. Non-nociceptive, peripheral or neuropathic, central, post-traumatic pain, stroke pain, all these things. Psychogenic pain means they are mental, emotional, behavioral factors. Headache, backache, some of the common causes of psychogenic pain. Eurosocial rejection, emotional event, grief, all these things will be there, but there is no nociception, no neuropathic mechanism. So these are never acute. Psychogenic pain is usually chronic. So what are the so many theories of pain have been come? So Aristotle believed that pain was due to evil spirits entering the body. It was due to an imbalance in vital fluids. It was thought as a punishment from God. So is a disturbance which passed along to the brain. So specificity theory. Body has got a separate sensory system for perceiving pain. A hearing core sensory system, vision core sensory system. Pain is separate sensory system. This is what is the first thing we started, that there is something separate for the pain. Pattern theory. He said there is no special sensory. If there is a pattern difference, something called, if you have touch or pattern of sensation, pain there is some pattern. This is what is called a pattern. Intensivity theory, if you slightly touch, it will be touch. Touch it hard, it will be seen as pain. That is what is called the intensity. We will go to Melzack wall gate control theory. Pain stimulation is carried by small slow fibers, which already we have done. A delta. We are not targeting A alpha or anything. Specific nerve fibers, yes, okay. Now, the small fiber area, pain is going, transmission, patient is having. Now, there is one gate. This is inhibited by this. This further inhibits so that the pain is more. But if large fiber is stimulated, this closes the gate and substantia gelatinosa is stimulated so that the transmission is decreased. This is what is called as the gate control theory of Melzack-Wall. So the gate opens and closes. This is what is the thing. If the large fibers remain unstimulated, large fiber we are not stimulated, pain signal will be continuously thing, and so that the patient will have pain. Now see here, there is a pain, headache. It is going on, patient is having a headache. Now we put some balm. We are stimulating the large fiber. This large fiber is stimulating the substantia gelatinosa plus, and the substantia gelatinosa is inhibiting. So SG acts as a gate to decrease the pain by just pushing as Zandu balm. So now we have one more thing. Patient itch and pain the same fiber. Now we have got itching, and it's now what we do is scratching. Now by scratching we decrease itching. We are not doing anything on histamine or anything like that. We are stimulating the large diameter fibers plus substantia gelatinosa. The simple example of gate control theory. So what is the neuromatrix? How does it work? So there are a lot of things which cannot be explained by the gate control theory. So the neuromatrix consists of multiple areas within the central nervous system, brain thalamus, limbic system, prefrontal areas, spinal cord, etc. They work together to produce a pain signature. This is what makes one to feel pain. This is what is called the neuromatrix theory. Only peripheral signals cannot elicit pain signature. So it has to be the impulse causing a work together of all these things. Limbic system, another affective component, because otherwise only sensory component. So all these things is what is called the neurosignature. Now this is biosocial psychological theory or biological factor. For example, tissue health or social factor, economic status, social learning, social support, or psychological factor, catastrophic thinking, hypervigilance, depression, anxiety, anger. Biosocial-psychological model of pain. So, for example, now we have a wound. This wound is causing pain, and a neuropathy is there. This also causes pain. This is biological. This is followed by patient is a depression and mental agony. This is psychological. Now, or he or she will be treated as a social outcast, where in HIV. So, bio, psycho, social, all these factors play a part in pain in HIV. This is what is called biosocial psychological model of pain. Now we will go to the descending influence. What is this descending control? Now we know from the nociceptor, prostaglandins, histamines, algogens are stimulated. It stimulates the peripheral nerves. It goes through the dorsal horn, lateral, all these things we know. This is what is called the ascending pathway of pain. Something called the descending control. We have rostral-medial nucleus, periaqueductal gray, the dorsal root ganglion, cortex. From there are a lot of things which passes into the DRG. This is what is called the descending control of pain. Pain modulation, in particular, the inhibitory modulation, what is called the endogenous analgesia. ஒரு பெயினை ஸ்டிமுலேட் பண்ணும்போது descending control வந்து கொஞ்சம் pain decrease. This is what is called pain inhibiting pain. From where the modulation? Thalamus, hypothalamus, brainstem. There are three things. Locus ceruleus. Here you can see the locus ceruleus. Nucleus raphe magnus. Here is NRM. Nucleus tractus solitarius. Here it is. Periaqueductal gray, here it is. So these are all the sites of possible areas or sites of descending modulation. How we came to know that there is something like that? For part of the brain, if you give stimulation, then it causes analgesia. Brainstem stimulation causes analgesia. If you stimulate a brainstem nucleus, it influences the dorsal horn to decrease pain. That is how we found out that there is something called descending control of pain. So normally opioids, noradrenaline, serotonin is involved, but now they have found out even GABA is involved. Modulation means inhibition and also sometimes facilitation by the way of glutamate. What I want to specify descending control is an exam question. Periaqueductal gray, opioids. Okay, locus coeruleus, noradrenaline. This is serotonin, nucleus raphe magnus. The prime chemical, periaqueductal gray opioids. This is norepinephrine in locus coeruleus. Raphe magnus, NRS, nucleus raphe magnus. Midbrain, pons, and this forms the brainstem. So ONS, PLR, opium, noradrenaline, serotonin. Periaqueductal gray, locus coeruleus, and nucleus raphe magnus. There is also called something called descending modulation of pain, the GABA. Yes, that increases GABA and decreases pain. It is also there in the descending modulation. Synthetic, non-synthetic cannabinoid drugs, they also influence the PAG and also the RVM neurons, thereby control the descending modulation. TRPV1 receptors, transient receptor potential vanillate type 1 and N-vanilloids. This is where our capsaicin works. Capsaicin, if you do like this, so it causes a burning sensation and it depletes substance P, thereby causing analgesia. So this is one of the causes of descending. Great paracetamol. They also say there is something periaqueductal gray. It stimulates the role of opioids in the bag. So it also stimulates GABA. All these things have been found out with paracetamol. This is my article, effect of addition of intrathecal midazolam. So spinal and supraspinal midazolam. It potentiates morphine-induced and agent-induced analgesia. GABA mimetic midazolam action. Spinal it potentiates morphine. That is opioid it has got influence. Opioids stimulate PAG that we know. Periaqueductal gray opioids. There is also a GABAergic pathway. Yes, contribution of pain in opioid tolerance. There is a small difference in tramadol because it also acts on the mu receptor and it also acts on the monoamine reuptake, serotonin, norepinephrine. Thereby, the descending pain is modulated. Yes, we all think that clonidine, release of norepinephrine, descending bulbospinal neurons, binds to the alpha receptor. Sympathetic outflow is decreased. That is when you give IV or IM. What does it do when we give? It increases the action of opioids. It causes vasoconstriction. This is more of an action when we give clonidine into the spinal, while we give parenterally, it is alpha 2 receptor decreased afferent pain transmission. What we thought was TENS, transcutaneous electrical nerve stimulation. If you keep the TENS paddles here and if you give a stimulation, it is likely to work like a gate control theory and causes pain relief. Now they say this pain relief is also due to a descending because contralateral stimulation. If you stimulate the left hand, there is a decrease in pain in the left hand. Right hand, how does it possible? So if you are going only by the gate control theory, there is some GABA changes, there is some enkephalin changes. Electroacupuncture. It has been demonstrated that electroacupuncture also we thought it is gate control theory. Now it has got some action on nucleus raphe magnus, 5-HT serotonin, and also in locus coeruleus as descending systems. Previously it was thought as only ascending systems. We have gotten, this is our article, post-stroke pain with acupuncture. Chronic primary pain is a new group of diseases with long-term pain and functional disorders. Without seeing fibromyalgia, temporomandibular disorders, this duloxetine venlafaxine, they have got increased serotonin level in the prefrontal cortex and thereby they influence the descending control of pain. Yes, they have now found out chronification of pain. Acute pain becomes chronic. I will take in one more class what is how they transform acute pain into chronic pain. Transition, how does it occur? That's a completely different topic. Descending pain modulation. If you want to go in a psychogenic angle, disruption of endogenous pain modulation by chronic pain alters cognitive and emotional processing. Yes, we thought all these things are due to spine and mesoencephalic tracts, causing in the what they say is a neural signature, neuromatrix involving the limbic system. But now they say even in the psychogenic pain, there is a role of descending modulation. Dysfunction of the central inhibition of pain has been influenced as chronic pain. But we think otherwise. There are a lot of manual theories, and we know descending modulation in so many manual theories. Manual manipulative theory, knee joint manipulation, ankle joint mobilization, all these things previously we thought ascending only, but now they have got role in descending control. Micro, see, non-steroidal anti-inflammatory drugs, brufen, diclofenac are supposed to act periphery on the pain site, but now they have said micro injections in the periaqueductal produces they release endogenous opioids. Some NSAIDs do they have a role in descending pain? Now we go to clinical dimensions. Why should acute pain produce a sympathetic response? BP raise a move, but fate raise a chronic pain does not. Now I have a ascending and descending modulation system. It is quite not, it's a roughly drawn, I'd say. If a site of pain, here there is an injury. From here it goes, crosses and goes above and here, and there is a descending modulation. Now if this is a site of pain, injury, now we can give local anesthetic here. Or we can give NSAIDs parenterally. So that prostaglandins and other algogens stimulation is decreased. Now it goes us through the dorsal nerve, dorsal root ganglion, enters the spinal cord. Here we can give a block. And then it goes to the ascending pathways. We can have neuroaxial, epidural, spinal. We can have, yes, here we can have alpha 2 receptors and clonidine. In the pack, we can have opioids. It also acts in the descending modulation system. Clonidine acts here also and here also. Duloxetine, it cuts the neuro. We have already told. There are some wide dynamic rodents. There is a role of 5-HT in the descending modulation. So duloxetine can cause decreased neuropathic pain and also descending modulation of pain is affected. Paracetamol is centrally acting and also some role in periaqueductal cleaning. Ketamine, where is it act? Thalamocortical projection system. That is where it cuts down the NMDA. Psychological, yes, I have told, anterior cingulate cortex, where we can change. So this is about a simple diagram of how many drugs compete and act in many places of the ascending and the descending pathways of pain. So if you want to do a summary, as definition, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Classification will be acute, subacute, and chronic, or where is it? Arthritic or malignant or appendix or anything like that, or nociceptive or non-nociceptive. Nociceptive whether is somatic and visceral, non-nociceptive whether is neuropathic, central, and psychiatric. In the theories, first is a specificity theory, intensity theory, pattern theory, gate control theory, neuromatrix theory, and biopsychosocial theories. We all know the descending influence from the PAG opioids, periaqueductal gray, locus ceruleus, and nucleus raphe magnus, the role of noradrenaline and serotonin. As I've already drawn a diagram to tell what are the clinical pearls are targeting drug therapy in very simple terms. There's so much in pain therapy, I'm not going into newer analgesics. So are we ascending too much? Can we descend slightly, look down, and look into these sectors?